So let's start with this image. I know it's not a fracture, but I just want you to know. Just want you to see the pad and the posterior fab pad of the elbow joint. Okay, so the anterior fab pad is normally seen, but it's not raised. However, the posterior fab pad shouldn't be seen. Okay, this is the posterior humeral fab pad. We are looking here at the elbow joint. Okay, so let's start the first case. This is the anterior fab pad at the elbow joint. I'm talking about the elbow joint here, not talking here or here. Okay, so this is the anterior fab pad is elevated with the sale sign, positive sale sign of the anterior fab pad. And the posterior fab pad, which is normally not seen, is seen here. So elevated anterior fab pad of the left elbow joint in a skeletally mature patient. Think of a radial head or olecranon fracture. So in adult, we need to check for radial head or olecranon fracture. I can't see any fracture here, but let's see the other case. There is elevated anterior fab pad of the left elbow joint, but I can't see the posterior fab pad. However, there is a fracture here. So this is a sign to look here. Is there a fracture of the radial head? Is there a fracture of the olecranon process? Yes, there's a fracture here of the olecranon process. So what about the pediatric case? The pediatric cases. So I've put here the normal elbow joint X-ray of a pediatric patient. So you can see the difference between it and the diseased one or a fractured elbow one. So this is the medial humeral condyle, lateral humeral condyle, and this is the trochlea, and this is the capitellum. So as you can see, trochlea is very smaller compared to the capitellum. So on lateral X-ray, you will see the capitellum. Okay, so this is the capitellum. This is the capitellum. Okay, and this is the humeral condyles. Okay, this is the epicondyles, the condyles. Okay, so on the lateral view, if you draw the anterior humeral line here, it will intersect the anterior 2/3 and the posterior 1/3 of the capitellum, as you can see here. And this means that there is no supracondylar fracture here. Okay, and if the anterior humeral line intersect the anterior 2/3 and posterior 1/3 of the olecranon process. This means that the olecranon process is normally located without any dislocation. Okay. Also, the anterior humeral line should, together with the proximal radial line, should together intersect the capitellum at approximately the middle of the capitellum, as you can see here. So what about this case? Okay. Let's compare here. So if you go like this, there's a defect here. So this is the supracondylar fracture. As you can see here, there is no fracture here, but there's a fracture here. And it's called supracondylar because it's above the level of the humeral condyles. So it's supracondylar fracture. Okay, let's see the fracture on the lateral X-ray. So if you go like this, there's no fracture here. No, if you go like this, there's a fracture here. There's a supracondylar fracture here. And if you go here, another bony defect. If you go here, it's continuous here. There's a defect here, so it's a supracondylar fracture. And if you draw the anterior humeral line like this, it will intersect the posterior aspect, the posterior 1/3 of the capitellum. Here it intersects the junction between the anterior 1/3 and posterior. Here it intersects the posterior 1/3 of the capitellum, and all of these are the capitellum. Okay. What about the olecranon process? The anterior humeral line intersect the olecranon process normally or as normal at the junction between the posterior 1/3 and the anterior humeral third, just like here. So the olecranon process is normally located. What about here? The anterior humeral line here intersects normally the capitellum, but it doesn't intersect the olecranon process because it is posteriorly located or displaced. So this is a posterior elbow joint dislocation. Another case here related to the elbow. This is a gouty olecranon bursitis.
Get Daddy, get.
This is a gouty olecranon. The olecranon bursa is markedly enlarged and and filled with heterogeneous soft tissue calcifications representing the gout C to 5. And this is usually seen in the latest stage of gout with probably renal affection. So, if this is the first presentation, but it's commonly a very late presentation of gout, and the patient is usually diagnosed with gout. But if this is the first presentation, I would recommend a rheumatology referral to guide care.